Thank you. Our chair, Dr. David Bangsberg.
Mm-hmm.
Kirsten Isaacson.
Present.
Brenda Johnson. Oh, you just said that she wasn't attending. Sorry about that. Dr. John Santa.
I'm here.
Rosenda Shippentower. And we'll reach out to her and see if she's able to join, and Zeke Smith.
Present.
Hi, Zeke. Thank you. And we do that verbally so that those who are calling in can hear. So thank you for that.
Great. Well, welcome everyone. It's great to see you. We certainly are going through continue to go through some challenging times with hopefully the Portland protests have reached a more peaceful state. But obviously our city has been engaged in really important work addressing anti-racism through hopefully peaceful protest, all in a time when COVID continues to move through the country. I think, OHA continues to do a really good job. We're doing really well compared to most states, but obviously COVID's come up, increased. There's more transmission in Oregon, not what we're seeing in Florida or Texas or Arizona, which is really very concerning. But in these uncertain times, it's really great to have you all come together to help support OHA, support our state to do this really important work. And I hope all of you are well, your family and your friends and your neighbors are well. And speaking of friends and people who've served Oregon really well, I'd like to acknowledge Zeke Smith, our former chair and longstanding Oregon Health Policy Board member. I think he has some important news to share with us during this meeting about an upcoming transition. Zeke, would you like to have the floor?
Sure. Thank you, Chair Bangsberg. Yeah, I have some exciting but bittersweet news, which is that I have taken a role to lead the Empire Health Foundation, which is in Spokane, Washington, and is responsible for a mission that is focused on health equity in Eastern Washington and the 7 counties and 3 tribes that are in the northeast part of Washington. So we'll be making a move to that part of our larger neighborhood as of October 1st. So I will remain on the board here through September, but will be tendering my resignation since I'll be moving out of the state. I've been on the board since 2013, and I think I know I have the longest tenure at this moment, and have really appreciated and valued my time on the board. I appreciate it was actually Governor Kitzhaber who initially appointed me, and then Governor Brown that continued that. I've learned a lot in this role, and also feel like the policy board over that period of time has more and more kind of found our way in terms of what our role is in the system, both in relationship to the Oregon Health Authority and to the legislature, and appreciate my fellow board members for the service and the continued work that you do, as well as Oregon Health Authority leadership. So thank you, Dr. Bangsberg, for that opportunity.
Well, thank you, Zeke. You have served the state, OHA, extremely well. You've been a great role model for us all in terms of how we can serve on this board. You're a great citizen, public servant, and leader, and Washington's really lucky to have you. We're really sad to see you go. So we got 1 more month. We'll make the best of it. We'll put you to work. We'll put you on 3 or 4 standing committees and do a few reports before we finish up.
Sounds great. Thank you.
All right. Thank you. Thank you. I also want to recognize that. So today we've gone back to our old 3.5 hour format that we had pre-COVID. I think we shortened the meeting because people were stretched at OHA in many different directions. They still are stretched in many different directions during this time of crisis and trying to respond to both important chronic work that needs to be done, but also the acute work, but now acute chronic work around COVID-19. I think we saw during our last meeting that there's so much that we need to attend to, so much we need to discuss. I think one of the best things that this board does is learn from each other. And frankly, last time we just didn't have time to really digest and share each other's thoughts on some really important work regarding incentive metrics, which we'll come back to this time. But also, so I've been working, Oscar and I have been working closely with Jeremy and Trilby and the whole team. And we collectively decided to go back to this longer format so we can have some more generative discussion amongst us all. And I'm really pleased to welcome you all back into this new format. And today in particular will be very interesting because we're going to hear from providers in the CCO and community stakeholders about how they're responding to COVID-19, to understand both how COVID-19 has impacted their longer term missions and those challenges and struggles that they're facing, and how they're responding to them. We'll hear those presentations. We'll have the chance for some short questions during the presentations, but we'll have a break, just take a breath and come back, and we'll have after the break, we'll have a time for generative discussion amongst us all. And I'll ask each of you to reflect on, what you heard during the presentation and, sort of how this informed, how these presentations inform our work. And as always, I always learn the most from hearing your thoughts. So I look forward to that part of the meeting. So now that's, with that in mind, let's turn to the minutes. And we'll welcome a review of the minutes and a motion to approve them.
I move to approve the minutes.
Mm-hmm. Do you have a second?
Second.
Any questions or discussion? All in favor? Aye.
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 Any opposed? Any abstain? Okay. The minutes are passed. One other comment for later in the meeting, we will have public comment for 2 minutes. I've received some correspondence. I think there are people lined up for public comment. Again, we'll have public comment or testimony for 2 minutes. We look forward to that. If you have public comment, you can send a chat message to Michelle Hatfield, or you can text 503-551-3881 to request a window for public comment and sign up. Okay. Steph, anything else I'm forgetting? We're on good. Okay. All right. So we will open up the meeting, our first presentation with Jeremy Van de Heide to talk about COVID-19 impacts the Oregon health system.
Thanks, Dr. Bainsberg. And I think we may have missed the director's update for Pat. I think we had it backwards. We thought you weren't joining till 10 and instead you're here till 10.
Okay.
So before I jump in, I don't know if you wanted to provide any updates.
No, I'm actually here all meetings. So although I may be in and out a little bit, so I can do it whenever you'd like me to do it.
Chair Bainsberg, I know you guys wanted to at least get a quick COVID update. Do you want to do that now, or do you want me to dive in?
Do we have, so Pat's not, well, let's hear from Pat and then we'll do COVID update. Yeah.
Sure. So well, I thought I was.
Are you later?
I think Pat is the COVID update.
Yeah.
Pat is.
So just
right.
very quick.
I'll let you two divide and conquer.
Right. So just very quickly, it seems like I keep thinking that we're into a new phase that's a more steady state, and it just turns into a new phase that's whatever the new kind of crisis-y state is right now. If you were to have asked me to do this 3 weeks ago, I would have been super concerned that we were on a rocket sled on our way from 300 cases a day to 400 to 500 and on up. Fortunately, we didn't do that. The steps that the governor has been incrementally taking for the past 6 weeks or so, I think have begun to bear fruit in the numbers. One of the things that's important to remember is that steps that we took at the very beginning of the pandemic that seemed to have an almost immediate impact, by the very nature of things, once you've opened things up and there are more cases and you're starting from a higher base of cases, they take the same kinds of steps take longer to have the same kind of an effect. And we're certainly seeing that now, where the shutdown back in March bore fruit within 2 or 3 weeks, and now we're seeing things take 3, 4, 5, 6 weeks before they have an effect. And we seem to be in a place where, at a minimum, our cases and hospitalizations have plateaued and are potentially now beginning to take a downward turn. That's compounded, unfortunately, by the fact that testing has again gotten to be a little bit of a difficult topic. We were at a place where we were testing really at a pretty good pace, given our level of disease in the community, and because of that low level of disease, the prioritization that we were receiving for testing supplies, we were doing on the order of 35 to 40, sometimes a little bit more, thousand tests per week. We've now seen that eroded significantly by a variety of supply chain issues that are not just us, but around the country. There are various data visualization platforms out there that will reveal that testing is eroding all across the country, and it's pipette tips for some kinds of testing platforms, and reagents for others, and collection trays for yet more. And so we're seeing this general challenge that there's not as much testing available as there had been before. That's got one, I think, one significant negative downside for us, which is, as we prioritize testing, we've still got ample testing to do things like outbreaks and those kinds of things. It's giving us a less clear picture about the overall dynamic across the state, and it's probably having an impact on our positivity rate, potentially driving that positivity rate up, partly because of the amount of disease that's in the community, but also partly because the testing is being prioritized towards those places where you would expect there to be more positivity around outbreaks and those kinds of things. I was on the call with Admiral Jorar, from a Deputy HHS Secretary, who's the testing guy in the administration, with the governor last week, and the news was pretty much don't expect this dynamic to change for the next several months. There are some investments on the horizon to improve testing capability, but not until toward the end of this year. So that's kind of our immediate challenge of the moment. And then I guess the last thing to observe would be, much like I think I've said to this group a number of times, there's not one pandemic nationally, there's 50 pandemics. I think there's not one Oregon pandemic, there's 36 pandemics, and in particular right now there's about 5 pandemics. And we've taken some steps to try to really deal with those very, very focused hotspots. The most significant are Umatilla and Malheur and Morrow counties, where you probably saw the news. OSU did its trace study in the city of Hermiston a couple of weekends ago, and came back with an assessment that nearly 17% of the population of Hermiston had COVID that weekend, which is just an extraordinarily high rate. The legislature has released now a block of funding a couple of weeks ago, and we expect they're releasing another significant block this week that will help address that. The first block was the $10 million of contact tracing, quarantine, isolation money that would go to over 100 community-based organizations that help us get what we don't have right, or we do now because the contracts are now finally in place, but it's that trusted local partner that are drawn from the communities that have a long history of serving some of the most affected communities in these counties. And what the legislature should be approving this week, as I understand it, is a block of $45 million to basically fund the kinds of assistance that's most needed to help facilitate effective isolation and quarantine. And that's really the big missing piece, particularly in these most significant hotspot communities. Last thing I'll provide just quickly for an update is we are in the midst now of standing up a coronavirus response and recovery unit. The idea is to create it as a full-blown shared service division between OHA and DHS that is responsible for the lion's share of coronavirus response work. It's the idea of how do we make this sustainable going forward. I've kind of tried to distinguish in our heads in the agency between coronavirus-driven work versus coronavirus-impacted work. There'll be some gray areas of exactly who's doing what, but if it's really coronavirus-driven, the reason we're doing it is because of the pandemic. We want that work to be done in the crew the CRRU, so that we can basically staff it appropriately, funded through disaster and coronavirus response resources, and basically allow the rest of the agency, much like this meeting, to get back to doing all the other work that we still need to do and can't just put on the shelf for 2 years. So let me go ahead and stop there and see if you've got any questions.
Open up for questions for the board.
Bangsberg, this is Zeke. I have one. Thanks, Director Allen. I appreciate the update and also the swift navigation through what continues to be a quickly changing environment. I just wanted to give appreciation for the release of the $10 million for the contact tracing and different supports in the community, and the way that those resources have actually been allocated specifically to communities where there's been overrepresentation in impacts from the COVID-19 influence. From the information that I saw in particular, that's with the Black community and the Pacific Islander community, and pretty good efforts in other places as well. And I know that resource continues to be allocated as applications are coming in, but wanted to call that out and just suggest that as you all move forward, paying attention to the way that that allocation of resources does or doesn't provide the health authority with, and Oregon more broadly, with the ability to address some of those acute issues in populations where we've seen those health inequities exacerbated, will be really, I think, valuable information to considerations for future strategies. So appreciate the strategy. Just a call out to pay attention to that, and in alignment with I think the rest of the conversation we'll be having today, it'll be really, I think, valuable to hear from some of the representatives from organizations that I know are a part of that strategy. So thanks for that.
I appreciate that. And just to build on that a little bit, we're trying very consciously to do these investments in a way that are not sort of super narrowly targeted toward a brief point in time around coronavirus response, but really become a foundational piece of public health modernization around capacity building and shifting our focus to this community engaged and partner driven kind of an approach.
Other questions for Pat?
And Dr. Bangsberg, I'm actually going to ask if we can switch to Jeremy so he can move and prep us for the panels that are starting at 9, and we will have time to come back and have additional questions for Pat later.
Thanks, Steph.
Thanks.
All right, let me jump in here. Michelle, can you do the presentation? I'm not seeing. Are you guys seeing the presentation yet? No. Well, while Michelle's getting that set up, let me just say I was going to just really try to tee up a conversation over the next several meetings. You're going to hear from a number of folks who are really on the ground dealing with COVID day in and day out, and you're going to hear a lot of their experience and experience from various communities, experience from the provider systems. So, I could probably talk for hours, which nobody wants me to do, about everything that we've seen. I think you're going to get a much better flavor of that over the next couple of meetings from presentations. So I just really want to hit some real high notes of kind of what we've seen in the health system. And I only say that to say that if I don't say something that's really important, just know that I think there's a lot more detail coming in other presentations throughout today of some real big impacts that we've seen in the health system. So Michelle, next slide, please. And overall, you can go ahead and go to the next slide. Overall, the purpose of trying to tee this up is again, just trying to kickstart conversations that you all will be having with stakeholders and various communities in the public. And where we want to drive this to over the next couple of meetings is really kind of a reset of OHPB priorities, not necessarily meaning that we're walking away from stuff that has been in the works, but just thinking about, in light of COVID, where do we really go from here, and want to do that through a sort of iterative process of some dialogue among board members and as well as discussion with various stakeholder groups. Where we had been before COVID, we really were on a track for a long time of trying to do two things in the state. get everybody healthcare coverage and make sure that it was high quality and affordable. We've been, as you all know, we've made huge gains on the coverage side, at least had before COVID. We're kind of still waiting to see how things shake out with the economy, but before COVID hit, had 94% of the entire state covered with health insurance coverage. But healthcare costs were really the challenge. And this chart, which I think you've seen before, highlights per capita healthcare spending in Oregon, the green line, compared to the national average, which is the gray line. Healthcare costs have been growing about 6.5% per person per year, or I should say healthcare spending, much faster than the national average. Next slide. The real impact for families and employers in the state had been there. The pressure on the premium growth was having, and as well as out-of-pocket cost growth was having on wages, on take-home pay. I think you've seen this slide a couple times in the past, but the takeaway is that from 2000 to 2017, premiums have been growing about 3 times faster than wages. Workers' contributions to those premiums have been growing 4 times faster. Deductibles have been growing even faster than that. And so we're really facing significant household and employer cost pressures for continuing to cover healthcare costs. Next slide. And then COVID hit, and we stopped elective procedures. We basically turned a lot of the healthcare system off, as well as the rest of the economy. And this chart shows what happened with healthcare spending nationally when that happened. So you can see this is a percentage change is what this is reflecting. So where the high level is on the left was basically where spending was before COVID. Then suddenly when elective procedures stopped, spending dropped dramatically, as much as 70% in different parts of the country. And then things started to pick back up once we started opening things back up in the economy, once we started opening things back up in the healthcare system. This chart only goes till May, and spending was still down about 40%. We've been hearing anecdotally that it may be closer to pre-COVID levels, at least in certain parts of the system, but certainly not in all parts. And there's major parts of the system that still are feeling very, very disrupted and are economically really struggling. Next slide. This also highlighted really the challenge that we have in the healthcare system of being in a fee-for-service system. We'd always talked about fee-for-service being a challenge in terms of containing healthcare costs, because by its nature, you're only paying for services that are provided. And so it creates this incentive to provide more and more services so that you get paid more. Well, this is the first time that I can think of where we saw the inverse of that, which was when we stopped providing healthcare services, people weren't going into the provider anymore, and then suddenly revenues plummeted. And so this chart just shows the correlation between utilization, the orange line, and revenue in the healthcare system. In April, both were down nearly 80% compared to last year. And this just shows that even though we've made major progress in pieces of the healthcare system in terms of trying to move to new payment methodologies, by and large, we're still in a fee-for-service system that is paid only when services are provided. Next slide. Despite the fact that we've now allowed for elective procedures, that people can go back into certain providers, there's still a lot of angst out there, especially in, I would say, the primary care community, behavioral health community, oral health community, where even though they are able to provide services, they aren't seeing folks come back into the doors, and that means their revenue is down, and they're really struggling to figure out what life is going to look like several months from now. This is data from a recent primary care survey of Oregon providers. And more than a quarter of practices reported less than 3 months of financial reserves. And this is a very different picture for primary care than, say, for other parts of the healthcare system, like certain hospitals who not that they haven't been struggling, but have been able to report much longer reserves than say 3 months. Next part of the system, or next slide, please. This is a pretty busy slide. I won't go through it in detail. This is just some more of the survey data from that primary care survey. The takeaway here is that more than 90% of practices expressed some concern about loss or reduced payment, even in light of, say, telehealth services and phone calls being covered in a way that they weren't before. They're being covered at reduced rates, and folks still aren't utilizing the system as much as they were before. So that really just paints the picture of the sort of ups and downs of spending in healthcare. We were growing much faster than the national average, then all of a sudden we're plummeting, and so the healthcare system's been sort of yanked into the opposite direction. The other piece of this is the economic equation that's going to hit us. Next slide. We've talked a little bit about this the last couple of meetings, so I won't go into great detail. But we're in a recession and going to be in a recession for quite some time. This is from this last revenue forecast in May, and just compares the length of recession. Back one, Michelle. The length of recession and how long it takes to come back out. And so even though they're expecting that things could recover relatively quickly next year, assuming there's a treatment that's widely available, employment numbers aren't expected to be back up till pre-recession levels until 4 years from now, basically. And that's assuming that there's a treatment that's widely available and things kind of start to get back on track next year. Next slide. From a state economic standpoint, the key takeaway here, just to look at this, just shows changes in forecasted revenue for the state. Just looking at the bottom line here, the change in revenue forecast for the state when you add up all the various revenue sources is a $2.7 billion reduction for this biennium, $4.4 billion for next biennium, and $3.4 billion for the 23-25 biennium. Again, the takeaway here is that we're going to be in this for a while and trying to pull ourselves out economically. So in addition to sort of spending in the healthcare system being up and down as a result of utilization, we also have a really significant budget challenge ahead of us. I will say on the 1921, well, actually, let me come back to that in a second. I'll talk about 1921 in just a little bit more detail in a second. Next slide. So what does this mean for the healthcare budget in Oregon? This is just a reminder of where people get healthcare coverage in the state. Or OHA provides healthcare coverage for about a third of the entire state, 1.3 million Oregonians. Those are the two blue slices. It's OHP, about 1 million folks on Medicaid, and then about 7% of the state that's in public employee programs. This does not include other government coverage, so local municipalities or special districts or some of those other folks. This is just state coverage, so the picture's bigger when you think about other government entities as well. But we provide a lot of healthcare as a state agency, which means that by that nature, there's going to be some significant impact on the state healthcare budget as a result of overall revenue being down. Next slide. Just to get an idea of what that overall could look like, we sort of bucketed the various state agencies into some major categories. Education is about 24% of state funds. OHA makes up about 17%. The Department of Human Services makes up about 7%. So when you add OHA and DHS up together and education, that's about half of spending in the state. And economic development is between OHA and DHS. A couple points here I just want to make. One, OHA is a large part of the budget. So just reiterating what I said before, there's no way that you can balance to a $4.4 billion reduction next biennium without some impact on the state's biggest agencies and biggest parts of the budget. The other point is that there aren't a lot of other obvious places to try to pull. Caseloads are in a recession. Caseload pressures on public on human services and healthcare grow. And the legislature is going to want to try to figure out how to meet the needs of struggling Oregonians and figure out how to make investments in economic development. And that's already where most of the spending goes. So it's not like there's easy places to sort of pull from to fill those budget holes. In terms of 1921, overall, we're less there. There are certainly pressures that we're going to feel and some pain this biennium, but we're much less concerned about this than what's coming in the next couple of biennium. Overall, things are fairly stable. We went through an 8.5% cut exercise, as we talked about a couple of meetings ago. The co-chairs recently came out with a budget that called for about $350 million from reserves and about $350 to $400 million of agency cuts across all agencies. That was much lower than the 8.5% cut exercise that we had gone through. They proposed keeping OHP benefits and eligibility stable. They did have some significant reductions in behavioral health, but overall things weren't as dire as the 8.5% cut that was originally proposed. Enrollment in OHP, there's a couple of reasons for that. Enrollment in OHP has not been growing as fast as we had expected. We've also had some immediate federal dollars that we can rely on. And as I mentioned, there are some reserves that the legislature can pull from. But there is still going to be some pain this biennium. And when the legislature meets next week, we'll get a final outcome of what the cuts are going to look like. And there will be cuts. Next biennium is really the challenge. If you just sort of for scale, if OHA had to take its 17% share of that 4.4 billion, and we balance that all on Medicaid, not that that's probably what we would do, but if that's where we tried to balance it, that would amount to basically $100 per member per month reduction in available spending. And so it'd be it's a real significant potential challenge. With that said, that there's still a lot of balls in the air. We don't know what reserves will be held over till next biennium. There's a lot of unknowns, and so it probably won't be that dire, but it'll definitely be difficult. Next slide. So kind of transitioning to where do we go from here? A couple notes on I think what we've learned from COVID so far. First, it highlighted a lot of structural problems in the healthcare system, a lot of which we knew about, things like challenges with being on a fee-for-service system that we just talked about. I think things that we maybe knew about but were much worse than we thought, like giant disconnects between parts of the system that really didn't talk, like public health and the medical part of the system and long-term care. We don't have great real-time data on what's happening in the healthcare system in a lot of places. But there's no bigger problem that was highlighted than the built-in inequities and institutional racism in the system. Second, we've just seen enormous fluctuations in spending in the healthcare system, and there's going to be more disruption to come. As we talked about earlier, things are not as dire in Oregon as they are in Florida or California or Texas or some other places, but we know that we're going to be weathering this storm for a very long time. And as we've had to lock back down Umatilla County as an example, I mean, we know there's going to be ups and downs and measures that go into place to try to manage through the pandemic, and that's going to create more economic ripples in the healthcare system. We've also seen though that the system can respond rapidly when we're really pushed, and I think an example of that is telehealth, which we've been debating for a decade, and suddenly we're able to really expand it. That's just a small example. There's lots of other examples out there. We've seen models of hospital level of care that suddenly have been developed to be able to provide care in home that's hospital level of care. So we've seen real quick innovation when pushed. Third, despite all that, there's going to be a huge amount of pressure to go back to the old way of business, especially when the system is still largely paid based off of fee for service. We know that this has exposed a lot of inefficiency in the healthcare system as well. We cut off all that spending for several months, and now it's starting to come back. But there's a big question out there of how much of that healthcare spending really was maybe not necessary. Certainly, there was damage and harm done to folks who needed healthcare who couldn't get it. But I think there's a lot of questions of, was there low value care that we didn't need to provide that we don't really need to be providing? An example of that is a $530 million estimate that we came out with a couple weeks ago of low value care that's been provided over the last several years in Oregon. And then finally, we're seeing the pressure of inequities in the social system overall. Without access to social supports and human service programs, it's incredibly difficult for folks to, especially folks with low income, to self-isolate or quarantine. And that's only going to get more difficult in a time where you're in a recession and have larger challenges on the human service budgets. Next slide. So where do we go from here? Just kind of putting this out there to start you all thinking about, as you're hearing from presenters and thinking about how do we start to kind of put the system back together, a couple thoughts. First, I think, and I'm hearing a growing recognition of this from healthcare leaders, that we've got to accept that there's no old system to go back to. We're going to be in this pandemic for a long time. There's going to be permanent changes as a result of it. And so that's probably a good starting point is that there's no old system to go back to, even though there's going to be a lot of pressure to try to go back to the way things were before. Second, we've got to do two things in parallel. We're going to have to continue to respond to the pandemic that's in front of us. And to Pat's point around, as an agency, we're building a long-term COVID response unit so that we can manage that. We'll also get back to our mission, which is really transforming the healthcare system and making sure that we have a healthy Oregon and that all Oregonians can really thrive. And so we've got to do those two things in parallel. So while we're continuing to manage the pandemic in front of us, we have to start thinking about how do we build a vision for what do we want the healthcare system to look like on the other side of this, kind of taking a long view as well, and starting to think about what are those incremental things that we can start doing now to help really rebuild to a better system, recognizing that we're going to have fewer resources economically in the coming biennia than we do now. And so we're going to have a system that can manage to that. So a couple of sort of, I think, principles to maybe think about that we've been thinking about internally as how do we sort of rebuild that system. First, thinking about really putting equity first and having a healthcare system anchored in health equity. We've seen over and over again where if we talk about disparities and inequities as a general goal, we sort of fix parts of the system, but those inequities continue. And so I think there's an opportunity here to say we're going to start really from an equity first perspective. And if we do that, we know we're going to build a better system for everybody. Second, thinking about how the healthcare system really focuses on all the patient's health related needs, whether that's public health, whether that's healthcare, whether that's social needs. Is there a way to rebuild a system that's simpler, easier to navigate for patients to get the care that they need that helps them be healthy, regardless of whether that's a medical service or something else. Again, recognizing that in order to be able to self-isolate and quarantine, there's a social needs aspect of that, recognizing that managing through a recession, there's going to be pressure on human service budgets. So can we think about really a system of health overall? Third, how do we really build off of the progress that we've made through COVID and go much further? So thinking about telehealth as an example, we've sort of advanced that very quickly. Now I think we've got a lot of concerns around, let's make sure that we're doing it in a way that doesn't create more inequities. But are there other opportunities out there where we can go a lot farther? Just the example I mentioned of there's models of care now to provide hospital level of care in home. So do we even really need to be building new hospital beds if we can provide some hospital level care at home? I don't know. That's a question that maybe we should be thinking about. Finally, none of this works unless the system's economically sustainable. And coming back around to the budget and spending challenges, we were on an unsustainable path before all of this. And so how do we rebuild a system that's one that we can afford? With that, let me pause and take questions, or I know we're a little behind. I think just kick it over to speakers.
Jeremy, thank you. That's a great framing. I think we'll pause on questions to make sure we have room for the community and CCO discussion, and then we can come back to this as we have our discussion after the break. So thank you. That is a great frame for the next section that we're going to devote our time to, and that's really understanding how COVID-19 is impacting community organizations and CCOs. And we're really fortunate to have Serena Cruz, the Executive Director of the Regina Garcia Memorial Foundation, and Olivia Quiroz, the Executive Director of the Oregon Latino Health Coalition and Oregon Latinx Leadership Network, to present first. Serena will have to leave at 10 a.m., so we'll have a chance to ask her a few questions. Olivia will be able, I think, be here for the remainder of the meeting for our discussion.
Great, thank you. I'm gonna share my screen with everyone. And I think that's, let me go back. Okay, so good morning and thank you for having us. Again, my name is Olivia Quiroz and I'm the Executive Director for the Oregon Latino Health Coalition.
And I'm Serena Cruz, the Executive Director of the Regina Garcia Memorial Foundation.
Okay, let's see. Great. So thank you for having us this morning. We're very excited to present to you and also to engage in some good conversation in terms of how to address and also for folks here on the call to learn and understand some of the barriers that the Latino community is experiencing. So we'll start with sharing about the inequities that we're experiencing in the Latino community, both locally and nationally as well. And then we'll go into sharing examples at the local level, at the statewide level, as well as providing some recommendations for the CCOs, for OHA, and for healthcare providers. But to kick us off, we're going to start with our colleague, Regina Garcia.
Yeah. Thank you, Olivia. We are going to talk about what we're seeing right now on the ground in our communities. So at Regina Garcia, we're the largest nonprofit federally qualified health center in the state of Oregon. The only larger federally qualified health center is Multnomah counties. So we're serving 52,000 patients throughout Washington and Yamhill counties. And when COVID hit, we immediately, the moment the state let us begin to test, we began testing in every single one of our clinics, as well as establishing outside test sites and drive-through test sites. And what we saw while we were doing this were incredibly high rates of COVID among the population we're serving, 60% of whom are Latino, and yet they were at the start 96% of our positives. And it wasn't too surprising when what we saw was racism, the kinds of opinions that folks have about these sorts of illnesses, and the systemic inequities, as Jeremy explained a few minutes ago. We know that this also comes from a lack of access to comprehensive health care, and that Latinos are 3 times more likely to be uninsured. And we represent 37% of all COVID-19 cases statewide, yet we're only 13% of the population. And while you might think this is simply an Oregon experience, it's not. As Olivia referenced, it is an experience nationwide, and one that requires a very focused response, strategic response. Olivia, did you want me to take the second as well?
Yes, you can go ahead.
Okay. So what we're seeing is that the reasons so many Latinos are affected by COVID has a lot to do with being essential workers on the front lines. And there's some amazing national statistics that we're 54% of agricultural workers, 35% of meat processing workers, and 29% of medical assistants, which places us in across industries on the front lines. Only 16% of Latinos can work from home, and there is no sick leave. And so it's great to hear about the state's effort to move quarantine support and assistance. That's happening for agricultural workers, but has not been happening for the rest of the population. It just started this yesterday for agricultural workers. And it's really critical that we find a way to do that for workers throughout the system. Olivia, did you want?
Okay, so I'll take on the next slide about our exacerbating inequities in terms of the economic impact. So Latino workers are also twice as likely to have been laid off as a result of the pandemic. They have also lost their employer-based healthcare coverage. And so this is adding to the uninsured rates that we're experiencing in the Latino community, and also knowing that the Latino community came into the pandemic with the highest uninsured rates for any racial and ethnic group, both in the state of Oregon and nationally. As people are losing their jobs or are being tested positive and needing to quarantine, people have less access to other social support networks. Being able to afford and pay your monthly rent or mortgage. Latinos also nationally at a higher risk of not being able to meet their daily needs. Food insecurity is also another big portion of that. With school closures, a lot of kids that were relying on the school lunch program, and those went away. We understand that some programs came back, but there's also a disparity and gap in that. I think that for our rural communities in particular here in the state of Oregon, the job loss, the access to all these social support networks is experiencing at a higher rate than folks here in the metropolitan area, where we have more nonprofits, more organizations that can assist and quickly deploy resources. But in our more rural communities, we know that our families are less connected and linked up to resources. And so this is becoming a big barrier for our communities. The discrimination in workplaces and housing. I think that, again, the Latino community, and in particular, farm worker community, came into the picture with a lower living wage pay. And so families were not being able to save for things like the quarantine that we're facing right now. Our immigrant and farm worker community still to this date experience discrimination in the workplace, and the housing for our farm workers are still not up to the standards that would ensure a healthy living facility. And so we also see a lot of crowded housing in some of our rural farm worker community, and this has led to a lot of kind of the discrimination that we still see today. This leads into the fear and anxiety in our community. At the beginning of this year, and then I think in the past 3 years, by the Trump administration, there's been a very direct and targeted approach in targeting our immigrant, our refugee communities. And policies like public charge that had been rolled out instilled more fear and confusion for families that were connected and receiving social support services and or programs, or getting support through other nonprofits or government assistance programs. And so families actually stop applying for many of these benefits. I think that the part around when we're talking about, these frank conversations about racism and what health equity means, is that we know that in our nation, our immigration systems and policies have directly impacted our DACA recipients, folks that don't have a pathway for citizenship, folks that are unable to apply for Medicaid program. And so we still continue to see a big healthcare gap in access. And this is based on this very discriminatory policies that don't allow for the adults in our community that have, depending on their immigration status, are not eligible for healthcare coverage. And as now we're facing a pandemic, the need to speak to a doctor or a nurse to talk about your symptoms, having that access is really crucial, and many mixed status members in our communities don't have that access. Social isolation, a lot of our immigrant and rural communities that are not connected to resources and are having to quarantine and trying to follow our health officials' guidelines and rules, becoming in our communities are becoming more self-isolated. And so with this, a lot of their mental behavioral health is also impacted. And we're seeing a lot of kids that also live in crowded apartments, the social isolation, the fear and anxiety is escalating, and fewer resources that are connected to our families create and exacerbate more of all of these inequities. And so we're very concerned about what we're seeing on the ground, and again, in particular in more of our rural community. So I'll talk about some of the areas that the Oregon Latino Health Coalition is working on in terms of building partnerships, raising the alarm, continue to share this type of presentations with policymakers in terms of what we're seeing on the ground, the barriers, as well as the recommendations and solutions. So at the Oregon Latino Health Coalition, we've been around since 2004. We're a statewide health equity organization. Our mission is to eliminate health disparities. And so one of the ways that we're working on the COVID-19 response is that we're leading policy and advocacy, both at the local and at the statewide level. At the local level, we're engaged with the Oregon Health Equity Alliance. At the statewide level, we are leading the health committee with the Oregon Latinx Leadership Network, who came together in February, and we're a network of more than 60 Latino members and allies, Regina Garcia being one of them, as well as many others that work together to address and set recommendations and raise the alarm around the COVID-19 and the impacts to the Latinx community. Our outreach and education is at the local and also at the statewide level. So OHC led efforts for the passage of the Coverall Kits, the expansion to the OHP plan for immigrant children under the age of 19. And we currently have a team of community health workers in the metropolitan area and Clackamas County to assist families in system navigation to get them enrolled into the Oregon Health Plan. And also right now we're transitioning into addressing their needs in terms of what they're needing for a COVID-19 response. The third one, at the local level, we're also partnering with Multnomah County Health Department, and we've been working with them to develop a Latinx COVID-19 response framework. So what that means is that they have funded 4 culture-specific Latinx organizations, Latino Network, El Programa Hispano, Familias en Acción, and the Oregon Latino Health Coalition. And we are now hiring and deploying a team of community health workers who are going to be working with the county's COVID-19 response team to ensure that families that need quarantine support and services connection to navigate their health, the healthcare systems. We're able to connect those families to the appropriate places that they need, as well as continue to look at what types of response the health department can do to address the outbreaks that are happening here in the county, and as well as sharing our lessons learned in the model to other counties that can also be possibly duplicated in other areas in the state. So I'll turn it over to Serena Cruz, who will talk about some of the local efforts at Regina Garcia.
Thanks, Olivia. So as I shared with you out the gate, the first thing we did was do as much testing as we possibly could. And the rates that we saw were extraordinary. They started in the mid-90s. They're now down to 87% positives for Latinos, which is still obviously overwhelmingly high. And one of the challenges that we're facing on our testing is consistent response time with respect to getting the tests back. So our corporate lab is LabCorp, and they average 3 to 5, but during a few weeks ago, it was up to 10 days, in which case our providers didn't even want to offer tests to our patients, knowing that 10 days to wait for a positive is way too long. Whenever we get access to the state lab, it's fantastic because we get a much faster response, but we don't get access, and we've been told we can't have access for all of our tests at the state lab. We can only have them for our specific events. And so we're glad to do that, but lab response time is a key barrier to our ability to let people know quickly that they have COVID, and then to educate them about what they need to do in order to reduce the spread. So that's a pretty key thing that we're seeing, and a pretty key gap. We've developed lots of partnerships in working with the community to address this crisis. So between the 2 local governments that we serve, Washington County and Yamhill County, we're in constant communication and collaboration with them. Washington County is investing in our activities. And then we partner with many local nonprofits in order to be able to provide wraparound services and supports. Our community health, we have community health workers at every single clinic, and they're working with patients around massive amounts of food insecurity, economic instability, all sorts of pieces about fear of leaving, their fear of fear of taking time away from their job because they would not be able to pay their bills, or alternatively can't go back to their jobs because they tested positive and their employer won't take them back even after the 14 days of isolation. So our social workers are hearing so many really horrible and traumatic stories every single day in the patients that they're working with. PPE distribution has been important, both in the distribution for our staff. Until dental reopened, we had very reasonable stores of PPE. With the reopening of dental, so going from purely emergency response during the peak of the crisis to now, we opened all 6 clinics back up. Their demand for PPE is incredibly high, and that's caused challenges for the rest of the system. And yet it's really critical that we be there for folks' dental needs. Dental needs are a clear part of their body. So figuring out the PPE components of things has become a new challenge again. And then we have challenges with enough masks for patients. Every single test that we provide, we give a patient a mask because community members throughout both counties have been contributing fabric masks to us. So we give a mask out with every single test that we take, but there aren't enough for the community. There are more masks needed in the community. We were a part of the initial distribution of KN95s to agricultural workers, but there hasn't been kind of an ongoing ability for us to secure those for agricultural workers, nor has there been an ability to secure them for other workers. So that's a challenge and also opportunity. And then, as I already shared with you, the stories of the health workers, they're really critical part of being able to deliver healthcare in this crisis. And it's an understanding that people's needs are not simply the telehealth or the video video appointment. It is really critically the kinds of conditions that they are living in, their challenges with their jobs, whether they can get access to the workers' relief fund or not. It really is a long list, and they're heroes everywhere in our organization, and certainly our health workers are heroes as well. Olivia?
Thank you. So the next two slides, we want to spend some time talking about the recommendations. And again, these set of recommendations were informed by our recipients from the Cover All Kids OHP program, as well as by rural statewide Latino leaders and allies under the Oregon Latinx Leadership Network, again, that came together in February to raise the alarm and to quickly mobilize organizations, our supporters, policymakers, into advancing and formulating these set of recommendations. Really, the intent is that we all here want to reduce the incidence of COVID-19 in our communities and in all communities of color, but in particular in the Latinx community, because we have our own set of needs. We want to continue to also come with this approach that the health inequities that we're experiencing right now are a result of structural discriminatory and racist policies over generations. And I think that that's what the first presenter had mentioned, how we got here to these inequities. And I think in the field, in terms of our public health investments, our healthcare systems, there has been disinvestments in particular that has led to these inequities. And so what we're starting right now is that we need a short-term response, an immediate response to COVID-19 right now. And we also want to lay the foundation for long-term investment, because COVID-19 is only going to impact the health and well-being in our communities in the long run. And so as the counties, as the state, as CCOs are receiving CARES funding, we're asking for this investment in our communities for the short-term and the long-term recovery. So what this means for us, based in our disparities in what you heard from both Serene and I, is that for one part is the expansion of healthcare coverage. As in the state, we've done some big wins in expanding to our immigrant children. But as soon as those kids turn 19, they're not enrolled into the Oregon Health Plan anymore. And so we need to figure out a way where we expand, either through this COVID period, healthcare access. The CDC recommends as soon as you have symptoms or you need to be seen by a healthcare professional. Many of our communities don't have that access to anyone right now, or the system in itself is very complicated with telehealth, that many of our families can't navigate that system or continue their chronic disease management, so puts them at a higher risk. The other piece is that we talked about is around increase in trained, culture responsive, and linguistic contact tracers. We're hearing in rural communities that they're fearing the information that is being collected from the contact tracers. They don't know if that information they share with contact tracers is going to be shared to ICE, and that they fear they might be deported. They might fear that they're going to lose their job if they are COVID tested positive, and that their employer is requiring that of them. So there's a lot of lack of information, and there's a lot of fear in our community, and kind of understanding what the role of a contact tracer is when they do reach them. And also that in our families, we, from a cultural lens, we have larger family networks. And so we're very protective of our community. And so I think that the way and the approach a contact tracer contacts their family really needs to be sensitive and through a culture responsive and trauma informs lens and training. Testing sites at no cost and also to be prioritized in rural communities. We know that there is a national shortage around testing, and this is something that we've known since I think April or March. And so as you're looking to prioritize vulnerable communities, we're asking you to prioritize our farm worker community, our essential workers, our low-income Latino families that don't have health insurance, that don't have the access to a healthcare provider, and that some of these testing sites could also be worked in partnership with us, community-based organizations, to serve as the bridge and connection to our communities, to ensure the families have the information that they need, and that the testing sites are also placed in settings that our community is familiar with, and so that we reduce many of the barriers. The other last two points that we want to share is that we talked about the wraparound support for food, rent, medications, and financial assistance. We want to thank the governor who launched the quarantine fund and who is also providing funding for CBOs. And as those resources are getting rolled out, we're also looking to other CCOs and other policymakers that can increase this pool of wraparound support so that us as organizations can better be able to assist our families. And again, a lot of these needs is more in particular within a rural community. The last one is that the messaging that we're receiving, the Latino community, we have been in a delay as far as getting information out appropriately to our community. We encourage a recommendation of develop a single set of messages in partnership with the community on multiple languages and on multiple platforms. Many of our families are not logged onto the internet. They don't have Facebook, they don't have Instagram, so the social networks can only go so far. So we really need to see these efforts being integrated and a larger campaign that really resonates with the communities, and also that is in different indigenous languages as well, because our community comes from diverse indigenous backgrounds. So that's all our recommendations for today. We want to, again, we're working with some of our community partners. We want to continue to work with OHA in raising the alarm and continue to figure out how to address these solutions. And I think that we might be able to have a couple minutes. And I also want to check in with my colleague Serena to see if there was anything else she wanted to add.
Thanks, Olivia. You really covered everything, and I know we want to get to some questions, so I'll just briefly say what we really need, and it's been great to see the resources directed out to the community organizations, but we need an OHA strategy. We need OHA to own a reduction in the incidence of COVID in the Latinx community as an urgent effort on the state's part that we are partners in doing. And that's going to take public health. That's going to take all of these items that Olivia has suggested. And it really does need a focused response. So even though the state is developing this COVID team long-term, clearly there needs to be a leader on that team who can marshal all sorts of resources at OHA and throughout the state to be able to focus on the crisis in the Latino community. With that, we'd love to take your questions.
Thank you very much for the presentation. Let me ask the board if they have a question. We probably think we can take 5 minutes for discussion. Well, we can have you both here. Zeke, did you have a question?
Yes, I do. Thank you. Thank you, Olivia. And I'm trying not to say Commissioner Cruz, but I just did. Serena, for the presentation. Thank you both for the work that you are doing and that you represent from the organizations and the communities that you're working with. Really appreciated the, and kind of thorough response in the presentation. You spoke a little bit to this, but I just wanted to give you another opportunity to reflect on how you think the Oregon Health Authority has or has not been responsive to the needs that that you all have surfaced from the communities that you work in, as well as other organizations like the CCOs. So as we're trying to really get a sense of the collective efforts to address some of the inequities that you raised, it would be helpful just to understand what you think about the responsiveness that you've seen from those entities. Thank you.
Thank you, Zeke. And your memory is old, clearly older than most folks around. But anyway, I'm really honored to be joining you all. And with respect to the state responsiveness, there have been elements that from our perspective on the ground that have been very responsive. So getting the resources out to support some testing and some outreach has happened with the agricultural workers. We're still waiting to see the details around how it's going to work with respect to the more general population, and how we'll be able to do wraparounds is not yet clear. And again, needs are so urgent, and I know that everyone's working hard, but figuring these issues out quickly and making the contracts long enough that it's possible to hire people hasn't quite happened yet. So I think those are key places where OHA can support us. But what we're really lacking is a strategy from OHA that is a public health strategy. So you are the public health experts, and we need that expertise to be focused on this crisis in the Latino community and helping us to figure out what are those pieces. This is a structural racism issue, which requires policies to be passed in response. That's how you address structural racism, in addition to dealing with resources on the ground. So resources have to happen, and I don't want to undermine that message at all, but there needs to be a thoughtful way to engage in those systems that are creating this reality, instead of just assuming that this is what we expect to see because Latinos are on the front lines, because they're agricultural workers. This is just what we're going to see, which is how it feels right now to the Latino community. It doesn't feel like the state has owned the urgency of needing to respond to this crisis in our community. 37% of the positives in the state, and that's not simply because there is access to testing. In some communities, there is no access to testing, and that's still happening as a result. So again, access to testing is one thing, but the incidence of COVID-19 in the Latino community is happening in every community in Oregon, and it's happening in every community across the country, and Oregon can do better. So that's my say on that. Olivia?
Yeah, and I think that we're also undercounted. So
Yes.
the data is a big issue. I think that that's one part that we don't have enough data collected to really understand what's happening and the reality of the tests and where COVID-19 is spreading in our community. I have not worked with any CCO at this point in this strategy. So I do think that there's a role for CCOs to play in this. And so we are, in our network, I don't think none of us have heard or more directed where CCOs are playing a role in terms of prevention, resources, to partner with us as the Latino community leadership and with OHA to really come up with this strategic public health framework. And so that's what's missing in this puzzle of trying to get a handle in this virus that is hurting our community and that is also killing members of our community. They're suffering. And so that's part of what we're sharing. We want to create, as you're creating those master plans, to work in hand with us so that we're all on the same page.
Thank you. It's really, we have a public health emergency happening in front of us. We take one more question.
I think maybe it's a little bit of a question and a comment. So thank you, Serena and Olivia, for presenting today. Really appreciate everything you brought to the table. There's definitely a lot of things that I learned this morning. And this is kind of in connection to Jeremy's presentation before yours. in which we're kind of hearing about, budget cuts that are coming our way. And all of a sudden, we also have a big, what it sounds like there's an infusion of funding coming from the federal government through the CARES Act. And some of that funding is sort of making its way down to community, and some of it is, making it down to community-based organizations like yours. Obviously, probably not enough of it. But I'm kind of curious to hear about, when we are creating the strategy that Serena is recommending that we create, is about sort of mitigating what's going to happen in the long term to make sure that we're not sort of like standing up some of these investments just in the short term for the next 6 months while we have the resources, but that it's actually a long-term commitment and a strategy. So I guess it's a bit of a comment, but also just a question in there as well about thoughts of how OHA is thinking about that long-term investment that goes beyond the CARES funding.
I think that you're right. And I'll use the community health worker workforce as an example. We came into this pandemic without a strong community, bilingual, bicultural workforce. And right now, the contracts and the resources that are trickling down to CBOs, we're barely hiring right now, and we're in August. And these are short-term contracts. And so I think that as we look at the long-term investment, how do we build the capacity of public health? How do you help us build the capacity of our infrastructure to respond to this pandemic? And how does this, for example, the community health worker workforce is invested in the long term? Because this is not going to be the only pandemic that we're going to see. There's going to be other natural disasters that are going to come our way. And so we really need to build a stronger infrastructure from a public health lens, a racial health equity lens, so that we're not just putting out fires.
Great. Thank you both. A really very powerful presentation. Really appreciate the opportunity to hear from you and for us to come back to this and figure out how we can craft and support a better response.
Thank you, Chair Painsberg. Thank you, everyone.
Thank you for having us.
We now turn to James Schroeder, CEO of HealthShare of Oregon. Welcome.
Hi, good morning. Thank you. Thanks for the invite this morning. As mentioned, I'm James Schroeder. I'm the CEO at HealthShare. I'm actually fairly new in this role. This is just my 6th month there. I'm a primary care provider by training, spent most of that in the federally qualified health center world, so fairly familiar with this space. I guess for context, it's important to note that currently HealthShare is responsible for about 358,000 OHP or Medicaid members. So around a third of the Medicaid population in the state. I didn't put together slides. I just thought that I would have a conversation around the different questions that were put out. I worked to try to gather input and feedback from all of our clinic and county partners. So I'm trying to, reference that as I respond to these questions. So the first question was around, how well the CCO is engaged with public health, contact tracing, and then follow up on positive cases. I think there's 2 parts to this. So on the engagement with public health, the metro area actually came together very quickly when COVID first started. We pulled together health systems, the counties, the CCO, and did very well on coordination around discharge planning. We pulled together a health systems work group. The CCO took a lead in the EOC with the health departments. We've since set up a testing work group to really try to monitor testing access and where is it impacting communities, and we're not getting the testing out where we need to. We also set up a COVID ops work group so that we could really focus how the responses are being done through public health, through Medicaid, through the health systems, and make sure that it was pretty coordinated. So I think that has all worked really well. We've had great engagement with public health. On the contact tracing side, it's been a little bit more challenging. I think that, the CCO with public health has a good connection, good relationship, and we're connecting on social needs and other things that come up as a result of people being quarantined. Where we still have some work to do is the connection back with primary care. Primary care is well aware when they have a positive case, if it's done through their lab or something that they ordered, or if somebody gets hospitalized. They are not always aware if somebody's gotten a test somewhere else and they've been approached by public health and put on quarantine. There's a lot of effort that's being put in to make sure that this coordination improves, but we're not quite exactly where we'd like to be there, but we're working on getting it there. We're also aware of some of the OHLC discussions around, with the DOJ and OHA around coming up with a COVID flag identifier, which could be a really great thing, but know that we're taking a careful and thoughtful approach to making that happen. The next question was around, whether we've seen documented poor outcomes in people with chronic disease. And, as Jeremy and others talked about already this morning, I mean, we, experienced the same thing where utilization went way down, especially during the shutdown of healthcare. That certainly has a lot of us concerned that we're going to see negative outcomes. As I called around, we really don't have the data that shows that we're having those poor outcomes at this time. It's something that we need to continue to watch, especially where we do have some concerning things that could lead to poor outcomes. For example, we know that immunization rates have fallen. We are definitely seeing fewer labs and kind of monitoring for people that have chronic disease. We've noticed that kids in particular have had a decrease in behavioral health visits. And as was mentioned, oral health was really shut down, and it's been very slow to get people back in and a lot of backlog. So we're nervous, that we could start to see some of those things, but we don't have the data that shows that we're having poor outcomes, just things that are indicating that we could down the road. Steps that we've taken around vulnerable populations with chronic disease. This is actually one that I'm really proud of. Within a couple of weeks of COVID starting, we quickly pulled together a methodology with our clinical partners to identify people that we considered higher risk during this time. And that was higher risk clinically, but as well as socially and other measures, including race and ethnic group. So from the beginning of this, or within a couple of weeks, we've been doing outreach to at least 65,000 of our 350,000 members on a pretty regular basis to check in with them to see how they're doing. We check in with them about their health, provide COVID information and a lot of clarification for people. We ask them if they're struggling with food or housing difficulties. And if they are, then we work on meeting those needs. We ask questions around mental health and substance abuse. And then we also ask questions around if they're experiencing any violence or have any concerns about domestic violence in their home. I have a whole bunch of stories that I don't have time to share about these calls, but the feedback from individuals, it really highlights the need, especially in this time. So many people are feeling socially isolated. And a lot of people, these calls are a big highlight for them. They comment about how it makes them feel like somebody cares and somebody's looking out for them. So these, besides checking in on their health and their social needs, just helping people deal with some of the social isolation that is very real during this time has been huge. We've used a lot of community health workers, MAs, medical students, and others to do these calls. So it's been a great use of a broader group of people to really do that. The other pieces that we're working on besides those outreach is, I mentioned the testing work groups. We're really trying to monitor where we have inequitable access to testing and change that. We have a broad group that's working on that. We've engaged school superintendents to start thinking about what can we be doing for kids and families during this time. One of our concerns with behavioral health going down with kids has to do with them not being engaged with a lot of their normal social structure like school, and want to be thinking about with them what are the things that we can be doing to get kids and families towards wellness, and that's really the goal. We also do a lot of work around foster kids, and we have some medical liaisons that work to really manage the 6,000 foster kids that we have, and that's been very successful. The other thing that we've been doing to make sure that people do have at least some telehealth access is providing cell phones and hotspots to people. Any of our members who are struggling with access to telehealth, we've made that available. We are still working on how do we do a little better job for people to make sure that they have technology literacy. Providing people with technology may not be sufficient. Not all of them know how to utilize it, or it's a scary thing for them. We also know that some of our population struggle a little bit more with telehealth access. We're getting better, but we're not perfect yet on those that prefer a language other than English, and telehealth, and getting that right. Like I said, we're not there yet, but working on that. We don't think that the folks that have serious persistent mental illness are accessing telehealth or feel as comfortable with telehealth, and that's been feedback from our behavioral health partners. We also see that elderly and kids tend to have lower utilization of telehealth and are trying to work to improve that. The next question was around resources and making things accessible. I already highlighted some of those things where we're providing the cell phones and hotspots. We've also provided dollars to behavioral health entities to provide stipends and incentives to their frontline lower paid workers, so that they're able to keep them on, so that these incredibly important frontline workers are able to do that. As I mentioned, we're doing all these outreach calls, which is a huge thing of really making sure that they're getting the resources that they need, especially where we're asking questions around food, housing, and other social needs, and then working with them to meet those needs through health-related services spending for the CCO and our partners. There was a second part to this question, which was specific to the recently released incentive or quality funds. So for us, and first, thank you to OHA for thinking ahead about getting those dollars out early. That has been really important. It was really important at the beginning of this to really help providers with sustainability. As Jeremy mentioned earlier, when revenues went way down because of utilization going way down, those quality dollars went from historically being used towards innovation to being used towards sustainability for a lot of our providers. So that's been huge. Of the 2020 dollars that we're receiving, we are actually setting aside a percentage of those to focus on community-based organizations, and specifically those that focus on culturally specific populations and communities of color. We have started to release some of those dollars, but are still in a process of really focusing those on these areas. So those dollars will go to places besides just the historic providers, although there are community-based organizations that are part of those kind of historical providers as well, and have been really, really instrumental in helping them. We also just did a funding for the Alliance of Culturally Specific Providers through these dollars. And we have ongoing funding that we've been doing actually for the last 3 years for OHPB around community health workers, and have those dollars through the rest of this year as well. The fourth question was around barriers that OHA can remove. OHA has done a really good job at trying to think ahead and remove a lot of those barriers. They pushed back a lot of our deadlines on reports and other things, which really helped free up space and time for us to focus appropriately on the pandemic and crisis at hand. I already mentioned the release of the quality dollars, which has been huge. They have made a real effort at partnership, transparency, and communication. But as you can imagine, with this being a very fast-moving ball game, occasionally, we could do better at coordinating and communicating, especially when things are kind of fast-moving. We'll sometimes find out, from public health something that's going on, and that's not any criticism, but that's something that we can all continue to work on, is really coordinating responses.
All of them.
We need continued help on making sure that the dollars that we're using for sustainability payments as well as HRS will count. And I think that OHA has done a good job of making sure that's the case. As already mentioned, there are challenges around testing delays, which certainly create a lot of barriers of knowing, if somebody has a positive and being able to quarantine and all those pieces. The last one is, thinking about FQHCs. They play such a critical role in this as one of our key safety nets, and they have some vulnerabilities, especially around oral health and behavioral health, as those services tend not to be in the alternative payment methodology. So they're very fee-for-service dependent, and we still have some challenges there. The last question was around concerns around the, status and stability of the delivery system. And, as was already highlighted, this pandemic has really highlighted a lot of vulnerabilities that we have in the delivery system. Most of the clinics really don't carry a lot of kind of funds that could sustain them for months on end, and that really got highlighted through this. We're hoping that this really pushes us more towards value-based payment and capitation as an overall healthcare system. We've certainly been moving a lot in that direction with Medicaid, OHP. We need to be planning now if there is another shutdown, especially of healthcare. As Jeremy mentioned, there's just very little in reserves for a lot of clinics. This will take a coordinated effort, not just with Medicaid, but with commercial payers and others, to make sure that providers have the sustainability that they need. Medicaid oftentimes is a very small portion of clinics' payment, unless they're a safety net clinic. And so we really need to coordinate that with the commercial payers. I already mentioned the FQHCs. We're concerned about the ones that are not participating in the APM, the alternative payment methodology, which allows them to be capitated for physical health. If they're not in that, they're very vulnerable for decreases in fee-for-service funding. And even the ones that are in the APM, their oral health and behavioral health are outside of that and have a lot of vulnerabilities. And there's some things that we need to be doing to plan for that. And then finally, I really appreciated Serena and Olivia's presentation. We have, I'm talking about the stuff that the CCO, has been involved with and doing. We have so much that we can still learn and improve on. I learned a lot from their presentation. I'm concerned about the sustainability of our community health worker workforce and a lot of our front, line workforce, as well as the people that have been doing a lot of our outreach calls, if they have to continue to do this for the long term. So overall, again, just want to thank you for the opportunity to share a few things. There's so much more that I could share, but tried to keep it within the 15 minutes that I had allotted. So thanks again, and I'll wait till the end for cross questions.
Thanks, James. Thanks very much. And also thanks for calling out Serena and Olivia for that presentation. I think there's a real promise for partnerships and obviously real importance to invest in community health workers. We'll continue, we'll have some time for discussion at the end of the next two presentations so we can discuss them collectively. And so I'd like to welcome Suzanne Cross, the Senior Program Manager for the Columbia Gorge Health Council.
Hi, thank you for having me. Can you hear me okay?
Yes.
I'm Suzanne Cross. I work with the Columbia Gorge Health Council, who partners with Pacific Source and the Columbia Gorge CCO. I wear two main hats in my role. I'm the CAC coordinator, and I also am the program manager for a program called Bridges to Health Pathways. That program employs community health workers throughout the gorge at various organizations such as public health, primary care, housing authority, hospitals, social service organization called the Next Door, and a youth shelter. And our community health workers work with people who are struggling to access resources on their own with 2 or more needs. I was asked today to come here, and I'm so grateful that you invited me to discuss the barriers, responses, and needs for the gorge. And I guess most importantly, I want to share that it takes really a community to address this pandemic, as we've heard from some of our speakers today. Many of the barriers that you'll hear about are likely some of the same from other small rural communities, especially those for whom agriculture is a big part of the community, like the gorge here. I guess I want you to know that some of the barriers started out as challenges that we were already able to overcome, and we overcame them collectively only because really the gorge thrives on collaboration. It's the work of the CCO, our CAC, our CAP, our Clinical Advisory Panel, public health, hospitals, clinics, food banks, schools, ESD, our local orchardists, our local government agencies, and our community-based organizations. It's really all of us working so crazy hard together that came together and organized in an unprecedented way to accomplish some pretty impressive tasks in the last 5 months. Some of the barriers for our region are still barriers after 5 months, and it seems still along each stretch of the way that new challenges are popping up every day. So I think, we started off sprinting, and now after 5 months, people are getting tired, staff are getting burnt out, feeling crisis fatigue, and the challenges such as the schools being closed keep coming. And it's definitely not a sprint, as we've learned. It's a marathon, a long one. I imagine that we'll have likely another 13 miles to go. And so with that, I'll tell you a little bit about the gorge. As I know, in most communities, COVID is disproportionately affecting our Latinx, tribal, and communities of color. Positive tests, as we've heard, of people who identified as Hispanic were 4 times that of others. In Hood River County, 83% of our positives were people who identified as Hispanic. Our partners from the Latino Health Coalition just shared that our Latinx communities are most commonly working in essential worker positions and thus more commonly being exposed. In addition, many of the social determinants of health, such as living situations, are really impacting people's ability to safely protect against COVID and prevent spreading among families and communities. In Wasco County, we had only 3 deaths, and sadly 2 of the 3 were tribal members. The housing conditions among our farm worker and tribal populations make it harder to spread out. For example, families are doubling up, and thus allowing the virus to spread more easily among those populations. Oftentimes, in these cases, quarantining a family unit with a positive test means putting half of them up in a hotel for long periods of time, which can be exhausting, scary, and challenging for those families. At the start of the outbreak, housing assistance support for undocumented workers was non-existent, as the Latino Health Coalition mentioned. Although the local orchard growers worked really, really hard to adapt their business to support the incoming migrant seasonal farm worker workforce at the start of our picking season, they increased housing options and spread people out as much as possible, but still there was shared kitchens and bathrooms, which caused a lot of fear among the workers when someone tested positive. Wasco County successfully has made it through their picking season. We're breathing somewhat a sigh of relief, while Hood River County is just beginning their picking season. We've also learned there are many barriers which can be frustrating when trying to access new funding streams that are coming up for housing assistance, for example. There's challenges with requirements on documentation, communication from landlords, etc., that can lead people to get frustrated and really just stop trying. Next slide, please. For our overall population, we're finding that food has been one of our biggest sought out resources since the pandemic. Our emergency food systems are being accessed 5 times more than usual. New people are coming in that hadn't ever before. And also when in isolation and quarantine, they need to make sure someone's available to bring families food and medication, cleaning supplies, and meet all their needs. And some people may have these resources and support networks and others may not. In addition, transportation needs were different in that public transportation was halted for some time at the beginning of March and April. For a typical harvest season, transportation is usually shared, and so this presented challenges for employers and employees Many of the migrant seasonal farm worker populations are now more spread out than a normal year, with not all living in the camps due to COVID. And so they needed COVID safe transportation to get back and forth between shopping and housing and their employment. At the onset of the virus back in March, information and education in languages other than English really lagged behind by weeks or months. And it's certainly something that I've seen, in particular, OHA doing a much better job, but something that needed, that we missed out on for a while. We've learned through our community health workers who've been doing outreach in the migrant camps that people received their information from social media, and it was often conflicting, confusing, and sometimes incorrect. And childcare was also and still is a big, huge challenge, as the normal supports for children of our essential workers were canceled, ended early, or were non-existent. And of course, now it's becoming our biggest hurdles as the schools move into distance learning for the near future or the long future. It'll take more than just the school districts, as was mentioned, to wrap around our school-age children in our community to make sure that they have a safe place to learn, food to eat, quality Wi-Fi, and adults to guide them as we attempt to teach them over the internet. And I think particularly about single parent families, essential worker families, families of dual income learners with young children at home. I can imagine for whom tackling the requirements of this school year ahead seems close to impossible. Next slide, please. Public health. Oh, sorry, the slide before that. There we go. Public health departments in smaller communities receive less funding than in their larger counterparts. They therefore have a limited number of staff under normal circumstances and have recently since repurposed all their staff to address the pandemic. They're often working 24/7 in order to be available and responsive to our newest positive cases. And of course, the region's cases don't come in Monday through Friday only. Bilingual staff are crucial to contact tracing, establishing trust, and really the message of isolation and quarantine, as was mentioned before, being delivered appropriately. It's important the information and instructions need to be performed in a trauma-informed way. We're lucky in the Gorge that our region really embraced trauma-informed practices a number of years ago, and both of our health departments in the region have been deeply involved in that work since. So we're feeling somewhat prepared, but still the challenges exist. Tourism is an issue, particularly in Hood River County, as our outdoor spaces have become crowded. It really limits where local residents can go safely to enjoy the outdoors. Also expands the risk of our essential workers in our grocery stores and local residents. And then the technology challenges. Many places in our counties don't have Wi-Fi or Wi-Fi that's strong enough to support virtual visits and distant learning. The schools made sure that each student had an access to hotspots at the end of the school year, and Wasco County was able to ensure that migrant camps had Wi-Fi access as well. And primary care clinics, as was mentioned, have really learned how challenging it is to teach patients how to do virtual visits when they can't be together and present. Next slide, please. So what has been the response in the Gorge? Our response is really two major concepts. I think they're collaboration and systems change. Organizations, programs, committees, coalitions have really all learned to pivot in response to the needs, the changing needs of our community. In particular, the collaboration across sectors, recognizing that one group can't do it alone and that we're really better when we do it together. Bridges to Health Pathways, a program that I run, changed from having its 14 community health workers working with clients in a more relationship building capacity in person out in their homes, changing some of their workflows to allow for a greater capacity to serve more people. We quadrupled our enrollments this month per month since April. The community health workers have been addressing needs over the phone, through texts, running errands on behalf of more vulnerable clients, and also for those with limited mobility. In addition, back in April, our program responded to by pivoting to support our two public health departments by providing wraparound supports for family and people in isolation and quarantine so that they can have all their needs met while they're in isolation. And as also was mentioned, we've learned that most people really struggle asking for help, but when they finally recognize that they need it and are willing to receive it, The responses have been really incredibly heartwarming. People have shared the appreciation for feeling that their community is there to support them in their time of greatest need. Other examples of our pivoting is that our clinical advisory panel held weekly calls, including hospitals and providers in Skamania and Klickitat County across the river in Washington, which they just recently started up again as our numbers are continuing to rise and our testing capacity continues to be limited. Our CAC continues to support bi-weekly virtual meetings, which is a partnership between the Public Health Department. We call it the Community Partner Q&A, where many sectors, including public health, come together and share what's new and what's updated, and people have an opportunity to ask questions of the organizations and of public health. Our COVID testing sites partnered with our local food banks and are testing in off-site locations throughout the region, while also providing food boxes to people who need them. Mid-Columbia Medical Center, the Bridges to Health Pathways program, and One Community Health did a tremendous outreach work providing education and masks, food, cleaning supplies to our migrant camps. But again, it wasn't just those programs working alone. They coordinated with each other with public health for mass supplies, with the food banks for food boxes. Primary care clinics and community mental health expanded their technological abilities on a dime to provide phone and now virtual visits, including virtual behavioral health visits, which as it turns out are quite popular. And the no-show rate is super low compared to our traditional mental health visits. Our emergency food systems, such as the Columbia Ridge Food Bank, local food banks, and gleaner groups are providing culturally appropriate food boxes along with gift cards. And people are super grateful to receive a plethora, apparently, of fruit and vegetables that they receive. Again, another partnership between our Gorge Gird Food Network, our local food coalition, the Gleaners, and the food banks. Next slide, please. Our local United Way was funded by multiple partners, including Pacific Source and the Columbia Gorge Health Council, to create a COVID relief fund. And within weeks, the Healthy Gorge Initiative opened up a simple one-page online request form for local nonprofits to apply. In addition, multiple partners, the Healthy Gorge Initiative, the Prevention Department, and North Central Public Health created online resource listings for the public and for community health workers to learn how to access all the new resources that are coming out and changing. The artwork that I've been using in this presentation are part of the Essential campaign, which is a partnership to promote artists and provide educational messages to fight racism and support healthy behaviors. Some of our CAC members participated in Spanish COVID educational videos sponsored by the Nextdoor Inc., which is a local community-based organization. And now those are being used in other communities throughout the state. Our local Spanish radio stations have been interviewing trusted medical providers in Spanish about COVID. And really miraculously, back in March, in a matter of a few weeks, a program called Gorge Outreach started, which successfully housed all the homeless people who wanted to be housed in both counties in 2 local hotels with support from healthcare and community mental health for wraparound services. And lastly, as I mentioned earlier, the schools and community partners also ensured that Wi-Fi was available for all students in migrant camps in places that it hadn't been prior. Next slide, please. And lastly, what do we need to make it through this marathon? Again, probably not too dissimilar from other rural communities. In a few short months, we'll need safe shelter for our homeless population. Neither of our warming shelters in the region are able to open because their previous locations were not COVID safe. We'll need funding to support a greater workforce to continue to meet the needs of the changing nature of the impacts of this virus on our community. We'll especially need bilingual staff with paid living wages to support the work needed in really all sectors. As Pat Allen mentioned, we'll need increasing testing abilities as our cases rise. We move into testing in our long-term facilities regularly, and as the weather gets colder and people get tired and start to gather indoors, we imagine our cases are going to rise. And then our newest and biggest challenge is supporting families for distance learning. Again, recognizing while this pandemic is hard on everyone, certainly impacts some in ways far more reaching than others. So as I polled my community partners in preparation for this, and we pulled all this together and celebrated really all that we've accomplished in our region, again, I go back to the thought that we still have so far to go. These last few months, we've been discussing at our Gorge Health Equity Collaborative how systemic inequities have been highlighted by this pandemic. And while taking so much away from us, it's given us also an opportunity to fix what's been broken for so long. Systems that haven't served people, equally now have a lens into what hasn't worked. And we really have an opportunity to make sure that in the coming months that people aren't left behind. So it'll continue to be all hands on deck. And since it was me who was asked to speak with you today, I'll share my own bias towards a certain workforce that we've heard about today a number of times, that for the Gorge has been a lifeline for many community health workers. I like to say that community health workers translate people to systems and systems to people. They've helped people understand how to navigate through complicated and difficult systems, and they really help our systems understand how to better serve the people that they work with. So I guess I'll leave you with that, and I want to thank you again so much for the opportunity to share our story.
Thank you, Suzanne. And we will welcome Carrie Pratchell, the Community Health Engagement Manager of All Care Health. Thank you. It's very good to have you here as well. We'll go to 10:30, which will give us 10 minutes for discussions from 10:30 to 10:40. Take it away, Carrie.
Great, thank you so much. Hi everyone, my name is Carrie Pratchell. I'm the Community Engagement Manager for All Care Health. And I manage the Community Advisory Councils as well as work on the Community Health Improvement Plan. I've worked closely with our communities during the pandemic, and I'm going to talk about our significant barriers in our service region, move on to All Care's response to the health inequities, and then finish with the needed health system supports. I really appreciate the comments from the other community presenters today. What they're sharing is right in line with what we have seen for health equity, and that it must be prioritized now, and there's no normal to return to for our health systems. Thank you for inviting me to share the Southern Oregon experience. So next slide, please. The significant barriers, I'd like to start off with a quote by Quinn Arrington, who's our tribal liaison for representative for All Care Health. The COVID-19 pandemic has made clear the distinct contrast between the haves and the have-nots in our community. The have-nots are Black, Indigenous, and people of color. Across our 4-county service area, we've heard from our partners that volunteers are down because vulnerable populations make up the largest volunteer base. Fundraising efforts are down with restrictions on gatherings. Robust guidance from the government is lacking. The need for equitable services has increased due to both disease impacts and economic impacts hitting the marginalized populations at a much greater rate. And uncertainty is magnified, with community members not knowing how they're going to pay rent, utilities, childcare, get their needed medications. Employment has been one of the biggest unknowns with the sporadic closures of businesses. One study predicts that restaurants that closed during COVID-19, 60% of them will never reopen again. Next slide. So resources have been provided from county, regional, and state levels. At its core, we're all trying to prevent families from falling off the cliff. The immediate crisis has been pushed out, but people are still struggling, and the pandemic is and will continue to impact our community members. We're seeing emerging state-level proposals for funding cuts. OHA has developed plans to decrease their budgets. School districts and early childhood programs will see less funding from the Student Success Act than anticipated. We're getting themes at the state level for a return to normal, but on the ground, there's nothing normal. Systemic structures and inequities built within Oregon's healthcare systems have persisted, even though the foundation of the AAA is intended to counter that practice. So achieving health equity requires the ongoing collaboration of all regions and sectors of the state, including tribal governments, to address the equitable distribution or redistribution of resources and power, and to reconcile, recognize, and rectify historical and contemporary injustices. Next slide. Next slide, thank you. Beginning in March, we heard from our community, our partners, and our care coordination staff that COVID-19 and the resulting shutdown was intensifying the needs of our members. This was especially true for those vulnerable populations living in our service area. In late March, All Care leadership dedicated the suspended 2020 withhold for the month of April to seed our COVID-19 Resiliency Fund. We immediately launched listening sessions with our councils and community partners to inform our grant prioritization. We've held the community at the center of all of our decisions and made our efforts transparent, even sharing our approach with other CCOs in our service area. By early April, funds were moving out the door to support direct services, modifications in service delivery models, tangible goods, and prevention of acute COVID-19 issues for our most vulnerable. We streamlined the application process to decrease the burden on the partners. We focused on key priority areas by empowering boots on the ground and making significant investments where we knew we could help a lot of people quickly. Beyond funding, we also increased communication to the public, both in English and Spanish, offered translation services, shared staff for county public health roles, and provided personal protective equipment. Our community investments are going beyond the immediate crisis, recognizing that COVID-19 will have long-term impacts on our community's health. The photo in this slide is a screenshot of our website detailing our community investments to date. The person shown is one of our staff members who's delivering food to those who are unable to travel for health reasons or transportation issues. Next slide. Listed here are several of our funded projects for organizations serving Black, Indigenous, and people of color. UNETE works with farm workers and other Latinx community members, and LISTO is a literacy program for Latinx parents. Both projects help with a variety of needs arising for these populations. Rogue Action Center's project helped counter evictions and find resources. We supported food accessibility both through funding and staff outreach in communities where transportation was difficult. We realized that some people with limited English proficiency weren't able to access the food sites and needed interpretation to manage the process. So we started a program to offer that support in Spanish. And we also provided services for other languages via video remote interpreting. Because of COVID-19, all assistance for at-risk families was suddenly gone. We heeded the governor's call to support positive attachment to reduce abuse and neglect, which has significantly increased during the pandemic, by offering programs that delivered activity kits and online parenting help. Shown here is a flyer for an online parenting class in Spanish that we funded and a front page story about our language outreach program instituted at area food banks. Next slide. All Care countered the pandemic on multiple fronts to ensure our members had the support they needed through payment parity for telehealth interpreters, continued payment of capitation to providers, even if health visits dropped significantly, provided iPads to members that enabled them to view ASL interpretation on a larger screen, provided remote equity training programs to area offices so learning could continue, increased access for the HIV preventive drug PrEP to the LGBTQ+ community, and provided LGBTQ+ culturally competent providers through accelerated telehealth initiatives. Before COVID, the Southern Oregon LGBTQ+ community identified a strong preference for these telehealth visits. In addition to these measures during the pandemic, we accelerated action for current inequities identified pre-COVID. All materials sent to members have alternative languages versions available. All 240 staff members are trained in equity, diversity, and inclusion. The availability of certified medical interpreters in the region has increased from 2 in 2016 to 127 right now, covering 13 different languages. Training and enforcement of certified and qualified interpreter provisions is embedded in our contracts to ensure that this is happening and available. Our health equity data work groups identify and recognize health disparities using the Real D components. And our branding department expanded our website language coverage and launched Spanish language Facebook and Instagram pages. Next slide. All Care's own work with the Regional Health Equity Coalition, So Healthy, to address language access in the region has been crucial to our work during COVID. AllCare has spent 5 years building an equity framework, resulting in a 25% increase in unique Spanish speakers seeking primary care providers, a 13% increase in effective contraceptive use in the entire Latino population. We're also identifying inequities and attempting to address the following: a 14% disparity between English speakers and Spanish speakers for emergency room utilization. Local hospitals have not engaged in language access initiatives yet. And African American AllCare members have the lowest primary care encounter rates. Some strategies to address these issues include addressing staff workforce diversity and hiring practices to be more representative of the community, addressing regional provider workforce diversity to recruit and support more diverse provider populations, continuing language access enforcement and support in the region, increased transparency in data reporting around Real D demographics, listening sessions and engagement with the African American community. Our 80-page health equity plan will inform our decision-making process led by Black, Indigenous, and people of color, along with LGBTQ+ individuals. Shown here at the bottom of the screen is the English and Spanish versions of our, Shown here is the link for the health equity plan that you can see. It's on our website. Sorry, next slide. We realize the critical role that our public health authorities are filling, and each of our service area counties have different needs for support. Jackson County was pretty well covered. Josephine County needed additional staff support, and Curriett County was in the middle of a public health transition when the pandemic hit. Here are some ways we offered support. AllCare provided translation and technical assistance to local public health authorities. Internal staff became public information and deputy public health officers for Josephine County. We paid for the public health officer in Curry County. We helped staff the Emergency Operations Center. We funded ASL interpretation for Josephine County press conferences, and we paid for the only COVID-19 testing site in Josephine County. For PPE distribution, AllCare helped get the word out to providers with direct communication and posting on the provider page, and also donated N95 masks. The link to the video that you see on the screen is a community healthcare COVID-19 PSA produced by AllCare and published by Josephine County Public Health. Next slide. So the supports that we are requesting: when we're given flexibility from the state and have financial resources, we're able to rally the community together and focus on maintaining services to members when people are vulnerable. Going forward, we don't see the same flexibility, and this will have negative consequences. We need more guidance from the state and CDC that is currently not provided. The state's intense reporting requirements inhibit our ability to dedicate resources to people and monitor outcomes. According to our Chief Financial Officer, AllCare is looking at a reduction of 3% due to a retro rate cut, further impacting our innovation dollars. The current system is set up for pilot projects, but we need to build systems that allow members to get healthy and then stay healthy through continuation of these projects. Examples of these include the Good Behavior Game, Hearts with a Mission in Grants Pass, Joe's Place, and the Grad Coach program. These are pilot projects that became proven programs, but we had to walk away because of lack of financial flexibility. In the case of the Grad Coach program, we did keep the coaches in the pilot project locations, but were unable to scale up the program to serve all the kids in our service area. We also miss out on a number of opportunities that require long-term commitments because the social determinants of health funding is not consistent. This is especially difficult when working with organizations who need staffing support, such as putting behavioral health coordinators in the justice system or language access specialists into non-medical settings. And really, at the end of the day, the OHA's policy decisions have effectively standardized CCOs to live in this perpetual pilot project cycle. AllCare would love to break this cycle. CCOs should be able to submit innovative health system designs that are in direct support of our community's needs. This slide shows College Dreams, which provides work internships for disadvantaged youth. We provided scholarships for this program in Jackson, Josephine, and Southern Douglas counties. Next slide. this is not business as usual, as you've heard from all the other presenters. There's a recognition from OHA and OHPB that CCO 2.0's implementation has been acutely affected by this pandemic. We would ask for continued commitment from OHA and the OHPB to allow CCOs to be flexible and innovative. This includes having the ability to maintain decision-making control at the local level, implement funding models that incentivize innovations in community-based initiatives, and a reduction of administrative burden to allow us to maintain the gains we've made over the last 6 years. This helps us empower local communities to prepare not just for the next 6 months, but also for post-COVID realities, with a focus on regaining ground lost during COVID-19. With a renewed commitment to addressing the equitable distribution of resources and power, we can continue to recognize, reconcile, and rectify historical and contemporary injustices. We and all CCOs want to be part of an accelerated response and solution to these emerging issues and existing inequities. And thank you again for the chance to represent Southern Oregon.
Great. Thank you very much, Carrie. Also wanted to recognize Rosinda Shippentauer, our Oregon Health Policy Board member, who I think was missed on the roll call. So welcome, Rosinda. So we have about 10 minutes for discussion.
And actually, if I could just jump in here for a second, since we had Director Allen speak earlier, we actually have a little bit longer. We can focus on Q&A right now if everyone's okay delaying the break for a bit. Okay. And then when you come back from the break, you'll have time for additional discussion among board members, but we'll let the presenters go by then.
So Steph, when do you want us to wrap up the questions before the break?
I think 10 to 15 minutes for questions is great.
Okay, we'll wrap up by 10:45. Questions from the board?
And all of the presenters, you're welcome to come back on video too.
John?
Yeah, thanks so much for these presentations. Can I ask all of you all, including the Latinx folks, what role, if any, are workers' compensation and commercial insurers playing in your community, coordinating with you, bringing resources to bear? Jeremy's slide shows there's a substantial decrease in utilization across commercial insurance, and I suspect there is in workers' compensation. So what's being done in your communities to bring those resources to bear?
So that's above my pay grade, so I'm not able to answer that question. But
others?
So this is James with HealthShare. So I think the way that I would answer that is, you know, especially if we look at the possibility of another shutdown and the fragility that would be out there for the providers, is we will need to include them in the discussions and the solutions. And, you know, that would be something that we really need to make sure that we have, you know, moving forward, because the payer mix, you know, for a lot of our providers is predominantly not Medicaid. So they would have to be there as part of that solution if we're gonna keep providers sustainable.
This is Olivia with the Oregon Latino Health Coalition. Yeah, I would agree. I think that these are important players to have a conversation. And for us, I mean, our outreach and enrollment programs specifically focus in the OHP, cover all kids population. And then in terms of commercial insurance, we see that there's a hesitation from our community to enroll. And so I think that there's also a need for like bigger information about what that looks like.
And this is Suzanne from Columbia Gorge. I think Not much that I'm aware of, except that we do have one pretty large payer in our region, Providence, and they recently handed out a handful of grant funding. They gave a bunch of money to serve really the larger community wraparound supports for our clients, and then funded a number of housing initiatives.
Other questions from the, thank you. Other questions from the board?
Dr. Bangsberg, this is Zeke. I've got a question. Mr. Schroeder, you spoke to the intent to set aside some of the withhold resources for community-based organizations. I'm wondering if you could share more specifically what that percentage is and what the dollar amount that represents. And then secondly, you spoke to a number of different efforts that HealthShare has had underway in terms of trying to address some of these issues, but I didn't hear much about specific and tangible results, and I'm wondering if you have any clarity about the kinds of results that you're seeing from HealthShare's engagement with community-based organizations in addressing health equities.
So the first one is fairly easy. So it's about $6 million is what that amounts to. And we've given out about $1.5 million of that. So just starting down that path. I'm not sure that I quite understand your second question. So you're looking for specific outcomes from like working with like the community health workers, like OHPB and things like that. Is that what you're looking for? Help me understand it a little bit better.
Yeah, in particular, part of what we were looking for in these presentations was an understanding of where you, as an entity and the partners that you have been working specifically to address the health disparities that we've seen from COVID-19. I feel like I saw that pretty well in the two presentations from the other organizations, and I'm wondering if you have anything else you'd like to share that articulates what both the intent has been, but also what the impact of those changes, because in terms of looking at the numbers, it doesn't really look like there's a distinction in terms of what's happening in the HealthShare region.
So, I mean, I guess I would go back to the, significant outreach that we've been doing with all the community health workers and other folks of calling people and making sure that they have their social needs met, which includes farm workers, Latinx, and other members of those communities. In fact, Regina Garcia is one of our key partners that's doing that alongside us as part of the network and doing that. We've done that through the behavioral health, outreach as well as the cell phones and all those types of things we've given. I talked about the $6 million, but there was a lot of other money that went out to providers that include providers like Regina Garcia and others, the counties that have gotten, significant dollars from those quality dollars that go towards these efforts. I guess trying to, what other, specifics that, that you would like, the testing, I mean, they're like Regina Garcia mentioned, they've been doing a tremendous amount of testing through their site out in Hillsborough, out at the stadium out there. And we have worked to set up other sites like that in other communities where there have been clear inequities on the availability of testing. So is that what you're looking for? Or is there something else that I could provide?
I mean, I think that's what you've got for now. So what I heard from Serena and what I heard from Olivia was a lack of coordination from CCOs. And so I think part of what we were looking for was to get a clearer sense of what CCOs are doing. Like I said, I think I got that pretty well from the other two. And I was hoping that we would see a little bit more specificity from HealthShare, but I think that it sounds like that's what you've got at this point. So thank you.
Mm-hmm.
I have a question.
Go ahead, Oscar. Yeah.
Yeah, I was really impressed by the mention of a health equity plan that was 80 pages long from All Care Health. And then I quickly just went onto the link to kind of take a quick look. Very, very robust, very impressive. I'm curious to understand, because I understand that health equity plans are probably a part of all the CCOs. Curious to know, a little bit about how All Care Health got to what seems like a fairly robust health equity plan, where it stacks up compared to other CCOs, and potentially how do the, sort of the counterparts of the CCOs work in tandem to sort of like potentially share practices or lessons learned. And then also, how does it roll up to OHA and back down? Part of trying to connect the dots between, Serena's comment about needing an actual strategy, like an OHA strategy. So I'm really happy to see that All Care Health has a health equity plan. I just want to see how the systems and the dots are connected. And I suppose that could be a question for Carrie, Suzanne, anybody who wants to answer that.
Oh, okay, sorry. Well, I can tell you, we worked with our community partners. Like I mentioned, it was with a lot of work with So Healthy, which is our regional health equity coalition or hub. And we have workforce teams, equity teams. I think there are 5 different equity teams in our company that reach out. It's not just internal staff members who are on this, it's community members, CAC members, and community partners who are doing that equity work, and people who are having the lived experience. So we definitely engage with as many partners as we can to get a really robust view and have an informed document. So I'm happy to share your question with my staff and have them get back to you if you want a more in-depth answer.
I can also share that the health equity plans are a new requirement of CCO 2.0, and they are due sometime in the fall. I'm blanking on the exact date, but we can get that to you. So that'll be an effort that we're expecting to see coming in later this fall, that OHA will be supporting and participating in, reviewing and assessing and providing feedback to that. And I don't know if Maria Castro or Leanne Johnson, I saw both of their names at some point, are on, but you'd be welcome to chime in now if you're here too. And otherwise we can come back with more information on what those look like.
If I could just comment a little bit too, part of what you heard was some concern about sort of administrative flexibility and overhead and those kinds of things. And if I take you all the way back to the beginning of CCO 2.0, part of what came out of a general sense that there was sometimes a lack of accountability for CCOs, and that part of what OHA needed to do in CCO 2.0 was do a better job of being clear about what the expectations were, and then hold CCOs accountable to delivering those expectations. I think we're going to be seeing an Inspector General report that's going to come out from HHS that's going to basically retrospectively make the same criticism that we've not done a good job holding CCOs accountable. And so a lot of CCO 2.0 were requirements like the health equity plan that asked and required CCOs to be a lot more detailed about what they were doing, more detailed about how they were engaging with their community to do that, and then have us be able to review those plans. And as your question implies, think about how those roll up into a larger equity strategy around the state. One of the effects of the pandemic has been a lot of pressure from CCOs to defer much, if not all, of those accountability elements of CCO 2.0. And so the date that Steph just talked about in the fall for the equity plans is something like a year later than what we originally expected to be able to receive that. And that's been true about accounting standards. It's been true about the equity plan. It's been true about much of CCO 2.0 in a recognition of the fact that we're all operating in a sort of a crisis mode. And so how do we continue to advance what we want to advance in terms of the 4 pillars of CCO 2.0, but reflect the way the world is right now. And so we're now in that stage of being able to get our feet back under us and go back to that notion of holding CCOs accountable. But there's candidly some friction and some pushback around that's worth being aware of, I think.
We'll let Pat have the last word on this part of the discussion, but we're going to have a break. We're going to come back for more discussion time amongst the board. And like invite our guests to stay with us if you can. And in this discussion period, we're going to talk about, our reflections of these presentations and in terms of what surprised us and, where our priorities should be going forward. So, more open, generative discussion. I hope to hear from each board member what their thoughts are from this morning and from recent presentations to the board. And Steph, when time do you want us to come back from break?
If we could come back at 10:55, that would be great. And for anybody who is interested in giving public comment or public testimony, if you could send that to Michelle via private message or text message, it's on the agenda by the end of the break, that would be great so that we can plan for the end of the meeting accordingly.
All right. Thank you. See you all at 10:55. And thank you so much for our guests for presenting and sharing their thoughts today.